So, hello, I'll be talking about pregnant dyspneic patient today. And the topic actually is really big. There are so many things to talk about. And I try to choose the topics that are most relevant to our practice, the things that we see every day, things that come in the exam, the board exam, and also things that I have seen in consult service. I don't have any disclosures today. And the things that I'll be talking about today, I'll be talking about normal physiology or physiological changes in pregnancy, embolic disease in pregnancy, and this includes venous thromboembolism, PE, amniotic fluid embolism, and air embolism. We'll talk a little bit about pulmonary edema in pregnancy, pulmonary hypertension in pregnancy, and asthma. Dr. Adish helped me put together this presentation. Unfortunately, she could not be here today. She's in McLaren. So we'll start with a question. A question says, during pregnancy, most pulmonary volumes and capacities change from the non-pregnant state. What value remains relatively unchanged? Vital capacity, functional residual capacity, residual volume, or tidal volume? What do you guys think? What do you think? Vital capacity. Any other votes? Okay. The answer is vital capacity. In summary, the major changes that happen in PFT in a pregnant woman, there will be a progressive decrease in the expiratory reserve volume. This starts minimal 8%, then it gradually increases to up to 40%. The residual volume as well decreases from 7% to 22%. And both of them, as you can imagine, happen because of the enlarging uterus and the diaphragm pushing up, so you really don't have enough space for reserve in there. Because of these changes, functional residual capacity in turn will decrease by 10 to 25% by the third trimester of pregnancy. Since these changes, the total lung capacity will slightly decrease as well. The vital capacity does not change significantly during pregnancy. And if you look at this diagram, you'll understand why. Like I said, expiratory reserve volume drops from the non-pregnant state to pregnant state. Residual volume drops, while the tidal volume slightly increases and the inspiratory reserve slightly increases. So this makes the vital capacity relatively unchanged despite the changes in the expiratory reserve volume. And I put these in my presentation because there were at least like 2 or 3 MCQs in the board preparation asking about these physiological changes. Another question, and this is just to see if you are listening. What's the major cause of the decrease in residual volume in a pregnant woman? Increased respiratory rate, increase in the overall vital capacity, elevation of the diaphragm, estrogen-progesterone hormonal interaction. The diaphragm, we just said that the uterine enlarges and the pushes up, the diaphragm is there, you don't have a lot of space to reserve anything. 30 question. What result would you find if you were to take an arterial blood gas during typical pregnancy? Compensated metabolic acidosis, metabolic alkalosis, compensated respiratory alkalosis, or respiratory acidosis? Yes, so when I look at this question, the first thing I'll look for compensated because these changes are long-term, so you have to compensate. This leaves you 2 choices, and respiratory alkalosis will be the answer. The progesterone specifically sends signals to the brainstem that increases the hyperventilation, and that's why it's responsible for this change that you see. All right, switching gear here and talking about embolic disease in pregnancy. We'll talk about pulmonary embolism and DVT, amniotic fluid embolism, and air embolism. This is a study that was done over like 30 years looking at DVT and PE in pregnancy, and trying to understand the incidence and relative risk of this. And it seems that the absolute risk that they found in this study was about 200 VTE in every 100,000 pregnancy that happens. What I find interesting about this study, I always thought that the chance of having venous thromboembolism will be higher during the higher gestational age pregnancy, but it seems that during 11 to 15 weeks is the peak of incidence of VTE in pregnancy. What are the symptoms of PE? When do you think about PE in pregnant women? It's very difficult because they do have symptoms to begin with. They are short of a breath, and they are not very different from the general population except for this part, and that's why you have to have high level of suspicion. This is a small study, but I found it interesting. Only 38 pregnant women. They had confirmed PE by CT, and they looked at the most common features of a presentation. Most of them, as you would expect, did have dyspnea. They did have pleuritic chest pain, some of them have cough, and about 18% of this population did have sweating as a presenting feature of their pulmonary embolism. I did put this diagram in here because it just showed up in so many pages in the board review, and if you listen to the board preparation also lecture, it's in there. And I noticed that they put more emphasis on the diagnosis of PE in that question more also than the treatment, and I found it very, very helpful to help you answer MCQs about diagnosis of PE in patients who are pregnant. So the first question you ask yourself when you see a patient who is pregnant, and do they have PE or not? And by the way, when I was moonlighting upstairs, I was consulted twice in the labor unit for the same question. What do we do? What's the next step if we think that patient has a PE and she's pregnant? So the first question you ask, does the patient have leg symptoms or not? And I always pray that they do because it makes your life easier. If they do have leg symptoms, swelling, or anything that makes you think that they do have DVT, the next step that you go for is going to be the compressive ultrasonography. I don't think this is working. Rodeo? It is? Oh, yes. So you do Dopplers if they have leg symptoms. And if it's positive, your life is easy just to treat whether they have PE or not. You're going to treat them regardless. If they don't, then the next step will be a chest x-ray. Now, this is something I myself struggle with. Like, I think pregnant women, I don't want to do chest x-ray, but as you know, you can just shield the fetus and then do chest x-ray. If the chest x-ray is abnormal, and then the next step will be a CTPE. Because what you see on a chest x-ray, if it's positive, you can't prove whether it's PE or something else. Could be just atelectasis or pneumonia, and that's why they're hypoxic or short of a breath or have pleuritic chest pain. If it's positive, of course, you treat. If it's negative, no. If it's inconclusive, then you have the question, should I do Dopplers or just repeat the CTPE? If the chest x-ray is negative, most of the patient will be negative, then the next step will be VQ scan. Only if the VQ scan is non-diagnostic, then you will go to a CTPE. How about D-dimer? Took this from the Journal of Obstetrics and Gynecology, published in 2009, recommendation about the use of D-dimer in pregnancy. They recommend against using it in pregnancy. And this is like now common sense, like think about malignancy patients, elderly patient, pregnant patient, we don't use it. But when you look at the evidence, actually it doesn't come from a very strong evidence why we can't use it in pregnancy. They take this conclusion from a study of 37 pregnant women with suspected PE. They had VQ scan and D-dimer. And it seems that the sensitivity in that study was about 73%, but when you look at the specificity is really low, about 15%. And the negative likelihood ratio, meaning the patient has the condition and the test, which is the D-dimer, is negative, was high. So it makes it not a good test to choose in a pregnant woman, even though it's a very small population. But in this kind of patients, you don't want to take any risk, right? So it's not a good choice. Also, if you look at the literature, there are a couple of case reports that say that there is a proven PE in a pregnant woman, CT, whatever they did, and the D-dimer was negative. So it's not a good choice. Question, this is from Seek. 27-year-old woman, gravida 2, para 1. She's at 35 weeks of gestation. She has dyspnea and exertion since her late in her first trimester, but it has worsened since a car trip approximately 2.5 hours in each direction. She now feels winded climbing a single flight of stairs. She also has some discomfort in her right anterior wall chest with deep inspiration, pleuritic chest pain, which is new since the trip. She denies cough. She doesn't have wheeze. She doesn't have fever or hemoptysis. There's no leg swelling or pain. And her past medical history is really unremarkable. She had no difficulties with her first pregnancy. There's no personal or family history of venous thromboembolism. Her only medication is the prenatal vitamin, and she doesn't smoke. You examine the patient. She is in mild respiratory distress. Blood pressure on the lower side, 96/52, heart rate 102, respiratory rate 20, temperature 37. Her SAT is 95 at rest, but when she walks it like 200 feet, it drops to 91. There's no JVD on exam, no chest wall tenderness, even though she had this pleuritic chest pain on the right side, and breath sounds are normal. Cardiac exam shows only tachycardia, no rub, no murmur, no gallop, and there's no lower extremity edema. They did a chest radiograph, and they shielded the abdomen, showed some atelectasis in the right base, and lower extremity ultrasound did not show any DVT. Now, if you remember the algorithm I showed you, it doesn't go through the steps that I mentioned, but this is on purpose to just confuse you a little bit. Anyway, the physician remains concerned about the possibility of PE and wishes to pursue further diagnosis. What test would you do next? CT of the chest, measurement of plasma D-dimer, transesophageal echo, or VQ scanning? What's that? CT scan. Correct. You were listening. So this is the algorithm again. She did not have like symptoms, right? They did the chest x-ray and it was abnormal, so they did the CTP. They also did the, yeah.
What's the sensitivity of leg syndrome? A lot of people may not have typical swelling.
Yes.
Especially when less intensive than.
Yeah, you're right. I honestly don't know a number. But if you think about it, if they do have like symptoms, it's easier. If they don't, I don't think it's going to be very helpful. But I really don't know a number.
Why have the VQ there is such an important part of the evaluation? I mean, what's the value? Why? So our algorithm in our head,
yes.
For everybody else, it's just a CT. So
yes.
Why would we use a VQ in pregnant women?
Less radiation.
Really that much different?
That's what I read. That's the only justification I found, actually.
And does it, I mean, when you have a 36-week gestation, does it really matter how much, the amount of radiation?
Yes.
When we have, if that baby's on the outside, they get CT scanned all the time.
Probably you were right. I mean, if the end of pregnancy, third trimester, is not a big difference, and personally, I would go for the CTPE. It may make a bit difference. But the only thing I found when I was reading this is the amount of radiation. That's all.
I thought the ventilation and perfusion part, the VQ scan together, actually connotated more radiation than the CTP part.
Oh, really? There was like 2 lines about this, and that's the only thing they mentioned. I did not look specifically in the amount of radiation. I took it
The actual, at least my recollection, is that you're supposed to do the perfusion scan. The perfusion scan is normal, you don't need to do the ventilation, and that actually is less radiation.
Okay, but there was, like I said, there was a small paragraph, and this just says radiation. That's the only justification they gave, and I did not go to that reference to see actually how much radiation is in there. What's that? I'm sorry?
The iodine.
Recommendation for the VQ is negative predictive value, plus different abnormal chest X-ray, then you have to expose the penis not to radiation provided.
Yeah.
Take that from.
I think contrast is free.
I don't.
Don't say that.
How about MRI? Like, I was thinking about this, and it's tempting, right? Because they don't use ionizing radiation, and you think it has less fetal risk. And there's no associated health risk with MRI. But what I found in the literature that the experience in using it in pregnancy and also non-pregnant women with PE is not very great, and they have a lot of inconclusive reading when they do MRI for PEs. I found this study, actually, it was a 300 patient. They were suspected to have PE. They were sent for CTP, and it was done. And after they had the CTPE, they ordered MRI, and they had 2 readers to read the MRI to see how much they agree between each other. Among the 300 enrolled patients, only 274 were analyzed, and out of these 103, about 37% did have PE that was confirmed by CTPE. And they look for, now we have 2 readers, reader A and reader 2, and look at reader 1, he had only 72% of the imaging from MRI were conclusive to him, about 30% were not, and this is about the same for reader number 2, only 70% were conclusive. If you look at the conclusive results from MRI, the 70% for reader 1, 70 for reader 2, the sensitivity and specificity was like 84% and 99% for reader 1, which is great, and 78 and 100% for reader 2. And if you take the inconclusive reading, put together the conclusive reading, it seems that the two readers do agree very well together about it. Now, the caveat that makes MRI not a great choice, first of all, we had about 30% of the images were not conclusive. And two, it's not as good as you get smaller PEs. It's great for proximal, sensitivity about 97 to 100%, but if you go to segmental and subsegmental, there is a dramatic drop in the number. It goes as low as 33%, so not very great. Yes?
PQ has a higher radiation exposure to
Oh.
the fetus than does CTV.
Okay.
It has a higher maternal dose.
Dr. Lazar, you were right. I apologize. I mean, it was just as justified by radiation. I did not look into it. Okay. I just put one slide about the treatment. Like you said, it's a very large topic. I'm trying to cover as much as possible about the treatment for VTE and pregnancy. And I put these from the ACCP guidelines just to tell you that they consider VTE and pregnancy as provoked. And as provoked, you treat it whether it's proximal or distal, and that the drug of choice is low molecular weight heparin. And why we choose this one? Because other agents can actually cross to the placenta. About the duration, they say minimum 3 months, and it has to include at least 6 weeks postpartum. I looked into the different practice and papers. Some of them actually, if the VTE happens early in pregnancy, they finish the therapeutic dose of low molecular weight heparin for 3 months, and they reduce the intensity to prophylaxis. Some of them just continue until you finish like 6 weeks postpartum. Now, amniotic fluid embolism, this was described early in 1920 by Dr. Meyer. It's very rare. The incidence is about 5 cases per 100,000 women given birth. Risk factor, women aged over 35 years old and they are pregnant. They have polyhydramnios, eclampsia, placenta previa, following cervical trauma, induction of labor, and instrumental vaginal delivery and cesarean delivery. So what happens is usually these present very close to delivery, and I think that the clue to this, if you find it in MCQ or something, is always after membrane rupture. They will give you a scenario where a patient had her membrane ruptured and then she became short of breath. What they believe happens is with the contractile pressure from the uterus, it pushes some of the fetal antigens into the maternal circulation. And they call it embolic phenomena initially when they describe it because it has 2 phases. The initial phase within 30 minutes, whatever enters into the circulation goes to the right side of the heart to the pulmonary vasculature and causes RV failure. Very high mortality at this stage, about 50%. And then there will be left ventricular failure and pulmonary edema, profound hypotension, and hypoxia. When you dig deeper in the pathophysiology, you see like anything that enters the maternal circulation can actually cause that, like discoimated skin cells from the fetus, lanugo or hair, prostaglandin or material from placenta like arachidonic acid metabolites. When they go in there, the immune system of the mother recognizes this as a foreign body and triggers all the endogenous mediators that cause the inflammation cascade afterwards, and it can cause DIC as well. So these patients not only will be hypoxic and hypotensive, but they bleed profusely. And this picture is actually more consistent with septic shock and anaphylactic shock than an embolic phenomena, but we still call it amniotic fluid embolism. How do they present? Most of them present with respiratory distress, like more than half of them. Some of them will be very hypotensive. Eventually, all of them will bleed. They will have profuse bleeding because of the DIC, and some of them can have also neurological presentation like seizures. I think it's better to put everything in a story kind of pictures to make you remember. So I put this scenario. 40-year-old white female, so as you can see, older mother. She's a gravida 2 para 1. She's 39 weeks and she is admitted for ruptured membrane. Remember, this is the clue. And she thought to be in early labor. 1 hour later, she was noted to have severe pain and tetanic-like contraction. Remember, this is what pushes the fetal antigen in the maternal circulation. And then there was a drop in the fetal heart rate to 60, and she was having difficulty breathing. She was desatting to 83%. They did emergency C-section and it was uneventful. The baby was born, baby was doing well. However, when they extubated her, she was not doing well. She dropped her BP, she's still desatting, and then they noted that there was a bleeding from the vagina and incision side and all the venipuncture side. This is the DIC part of it.
Just hide it. Just hide it. And just keep on going. It's gonna be like hide it. Hide. Hide.
I'm clicking.
Just keep on going. It'll take you, how many more minutes do you have to go?
Not a lot.
That's gonna, that's 15 minutes.
We'll just
Okay.
take off for you.
Now, air embolism, it can happen in normal labor, can happen with patients with placenta previa, clonal abortions, abortions using suction, and encephalation of the vagina during procedures and douching. So what happens is large amount of air collects in the right ventricle, again, comes up from the venous system and then goes to the right ventricle. If it obstructs the outflow, then it can be fatal and mother can be in failure and die. If it goes to the pulmonary vasculature, what happens is that you'll have pulmonary hypertension and RV failure and some pulmonary edema. But luckily, these air embolism can be resolved very quickly, so these symptoms are usually transient. But if they obstruct the outflow, that's when they become fatal. Now, I think this is a very interesting part. I was looking at case reports and presentation of air embolism, and I find all these weird case reports in the literature. This is the first one. Venous air embolism following orogenital sex during pregnancy. Seems that the most common cause for this is actually that, like insufflation of any amount of air in the vagina near delivery can lead to this, and patients can die. This patient was actually 38 weeks pregnant. She had hypotension, metabolic acidosis, she had C-section, and then eventually the baby died. Venous air embolism after using a birth training device. I don't know what's the birth training device actually. I never heard of it, and it seems that it's something that stretches the perineum, so it can insufflate air and then it can cause air embolism. Being there, I don't think anything can train you to have birth. Honestly, I don't know why someone would use that, but anyway. There was also maternal fetal death due to vaginal encephalization of cocaine, something you can see in this part here in our population. It was sudden death of a mother. She was 31, she was 39 weeks, and there was encephalation of cocaine in the vagina orally and led to air embolism and death. I think what's frustrating about all these cases, like they are all like 38 and 39 weeks. They went through all the pregnancy just for the last day to do something stupid and then die. Sometimes it's caused by medical conditions like rectovaginal fistula. This woman did have it before pregnancy, and she presented with placenta abruptio and air embolism. Question. 27-year-old woman who was at 30 weeks of gestation with the twins. She's admitted to the delivery unit because of a preterm labor. She is treated with bed rest and hydration. However, because of regular uterine contraction and some cervical effacement, she was given IV terbutaline. 2 hours later, she complains of shortness of breath, and physical exam is notable for a pulse of 96, blood pressure 126/82, respiratory rate of a 24. There's JVD on exam, bibasilar inspiratory crackles are noted, and her X-ray shows diffuse alveolar filling process without cardiomegaly. Her coags are normal. Which of the following is the most likely explanation of her dyspnea? Amniotic fluid embolism, peripartum cardiomyopathy, pulmonary edema secondary to terbutaline, or pulmonary embolism? Cardiomyopathy? What do you guys think? To terbutaline. That's the answer actually, Julio. So secondary to choleitics. It's again something that comes up very frequently when you prepare for your board. You'll see MCQs about that actually. So pulmonary edema and pregnancy. This is a review study of 62,000 pregnancies from 1989 to 1999. to see pulmonary edema diagnosis. I look in the chart, looking for diagnosis of pulmonary edema to see the different causes of pulmonary edema in pregnancy. The mean gestational age at which pulmonary edema occurs is 31 plus 6 years, so the third trimester is the most common time for pulmonary edema.
Keep on talking.
Okay. The diagnosis of pulmonary edema was made in the antepartum period also in about 47 patients, intrapartum period 14 patients, and the rest were postpartum. So if you look at the most common causes for pulmonary edema in pregnancy, actually it's tocolytic. So you think of cardiac disease, yes, they do exist, very important. Most likely you will know about it before the patient gets pregnant, but tocolytics are very common causes. We don't think about them very often. Fluid overload and preeclampsia could be other causes for pulmonary edema too. So those patients who did have pulmonary edema because of tocolytic use, they did receive multiple ones of them, and most of the time at the same time, like more than one agent. So it doesn't take like usually one dose for you to have that. And the most common combination that leads to that is magnesium sulfate and terbutaline subcutaneously. How does this happen? It remains really poorly understood. We are not very sure. Pulmonary hypertension in pregnancy. Maybe Dr. Mendes can help. It's a very difficult subject. I borrowed these slides from Dr. Kehiges and Dr. Arish. There is like a 42-page statement about pulmonary hypertension in pregnancy. It goes through the details, and I'll try my best to explain what I think is most relevant to us. So first of all, you have to understand the physiological changes in the cardiovascular system in pregnancy, and then you will try to compare to the possible changes that happen if the patient has pulmonary hypertension. So cardiac output and plasma volume significantly increase, as you can see here in red, and MAP does not really change. There is a drop in the middle trimester, but then it goes back almost to baseline. The systemic vascular resistance on the other side, it drops significantly, and this is very important because if you're going to flood the system with a lot of plasma volume and cardiac output, you need a circulation that can accommodate that. What happens in the pulmonary circulation is not very different from the circulation, and there will be a decrease in the pulmonary vascular resistance, and this is all hormone mediated. There will be recruitment of previously non-perfused pulmonary vessels to accommodate all this change and the increase in the plasma volume, and this will lead to normal physiology if you can open more units to accommodate all the volume that you have accumulated. But if you have pulmonary arterial hypertension or pulmonary embolism, you can see how difficult this would be because the plasma expansion and the cardiac output will increase, but you don't have the capacity to accommodate these changes, and this puts extra pressure on the RV and leads to RV failure. This is just to illustrate what I was explaining. In normal situation, you can accommodate the change, the increase in plasma volume, as you can see, compared to non-pregnant state, but you are recruiting more units to accommodate that. If this is impaired, then the RV will be strained and you will be in RV failure. So trying to understand what happens altogether in pulmonary hypertension patient is very complicated because there are so many factors that play in the change that happens during that time. It can be hormonal, can be volume related. So if you look at the red boxes, this is the underlying whatever abnormality is there in these patients, right? They can't vasodilate, they have RV dysfunction, and they have pulmonary vasculature remodeling. And then you put on top of that the new factors that happen in pregnancy, the increase in volume and the hypoxia, which worsen these two, pain, and also if they develop PE, also worsen these two along with acidosis. This is easier than trying to understand the hormonal effect on all these changes because they do play dual role. They do help sometimes and they do make the things worse sometimes. If you look at pulmonary vascular remodeling, it's very difficult to understand what estrogen and DHEA, dihydrogen does to the pulmonary vasculature remodeling. Some literature say that even in non-pregnant women, why women have more pulmonary hypertension because of these hormones that promote vasculature remodeling. So in pregnancy, this even gets worse. When you go to vasodilation, these hormones prevent vasodilation, making the problem worse. What's interesting though is their effect on the RV, because estrogen actually promotes the RV function, increases the stroke volume on the RV and the ejection fraction, while the testosterone has the opposite effect that make it fibrose and reduce the ejection fraction of the RV. So even though there is a good part of the hormones that promotes the RV ejection fraction, remember that these effects will fade away very, very quickly after delivery, and then you have unopposed effect of the testosterone on the system, so the RV ejection fraction will drop even further, and that's why the postpartum period for pulmonary hypertension patient is very, very critical. They need to be admitted and hospitalized, you need to give them Lasix, limit their fluid intake, and do echo every 2 weeks. I don't think I'll go through this. This is about delivery. I don't think it's very relative to our subject here. But what I want to say is that, pulmonary hypertension carries a very high risk of mortality. Those who have Eisenmenger syndrome can have mortality up to 36%. If they have idiopathic pulmonary arterial hypertension, it can be as high as 30%, and some literature say it's 17%. Usually it's early postpartum period, like I said, is the most dangerous, and mainly that's because the volume expansion continues weeks after you give birth, but you don't have the protective effect of hormone on the RV, and you still have the testosterone, like I said, unopposed effect, so it's all bad. Patients and medication with pulmonary hypertension. If they are on IV prostanoids, continue as they provided. If they are on sildenafil, consider switching to IV. And if complication happens, consider increment dose of the prostanoids and adding inotropes. Does this and any of that work? Probably very unlikely. It's a very risky situation. Finally, I'm going to be talking about asthma and pregnancy. I borrowed these slides from Dr. Olet. I sent him an email and telling him how much I love his presentation. I actually keep it as a resource. I find it very, very helpful. Thank you, Dr. Olet. So the classic teaching about rule of third, you all know this. 1/3 of them get worse in pregnancy, 1/3 remain the same, and 1/3 get better. What makes you predict which patient will be better and which patient will be worse? It really depends on two things. First of all, how does their asthma behave before pregnancy? And two, if they had prior pregnancies, how did they do? If they did worse in their first pregnancy, most likely they will do worse later. Also, asthma tends to be less severe in the first and latter third of trimester, and it's worse in the middle trimester. Why do we worry about asthma and pregnancy? Because of the poor outcome that's accompanied by asthma and pregnancy. They do have more incidence of preeclampsia, preterm birth, low birth weight, and congenital malformation and perinatal death. So this study, about 200,000 patients given birth, some of them did have asthma and some of them did not, and they compared them logistic regression model. And then they took the group of patients who had birth and they did have asthma and compared those who presented to the ED or got hospitalized, those who got one course of steroids to those who got more than one course of steroids, and they looked at the effect on the birth weight. To have asthma to begin with means that the birth weight will be lower. Chances are, if this patient goes to the ED or gets hospitalized, that's even going to be worse and worse, as you can see. And those who get more than 2 courses of steroids will have significantly higher drop in the birth weight compared to those who get 1 course or never. If you look at the different outcomes as well, 2 population of asthma patients here. The circle ones are the one who did visit ED and got hospitalized for asthma. The one who are squares are the ones who did not. Whether they did or did not, as you can see, the chances of poor outcome is much worse. Low birth weight in those who did attend ED for asthma exacerbation, C-section chances are higher, antepartum hemorrhage, preterm labor, membrane disorder, and also hypertensive disorder of pregnancy. So it puts you and your fetus at very, very high risk for all these poor outcomes. Something I also always forget, can't remember on top of my head, I always go back and look to see categories of medication, FDA categories for medication for acute management and also control. So as you can see, most of the drugs that we have to acutely manage asthma are either group B, category B or C. The preferred one is albuterol, just like the rest of the population, and it's category C. If you look at the controller, the inhaled corticosteroids, the preferred one is budesonide. Again, most of them are B or C. We don't have A. Still use them. Stepwise approach to treatment of asthma and pregnancy, not very different from the general population. Preferably that your patient is doing well, they'd only need the acute management, which is albuterol. If not, what control medication you do, just the same way we do it. Okay.